Hello, my name's Trish Phillips. I'm a area matron for specialist services, and I have a long career in cardiology since 1984. I've been a facilitator with Education for Health now for over 10 years. Today we're going to have a look at non-pharmacological management of CVD, and we are going to look at the risk factors and lifestyle modification and look at some consultation skills. So what do we mean by CVD, cardiovascular disease? Cardiovascular disease is a systemic disease. If you have furring up in your coronary arteries, then you will have some furring up in other arteries. It's an umbrella term. It causes things like chronic kidney disease, CHD, peripheral vascular disease, stroke, which is the fourth biggest killer in the UK and most common cause of death worldwide. And I'd add into that vascular dementia. Vascular dementia is the second cause of dementia in 1 in 4 cases, and there are at least 150,000 people with some form of vascular dementia in the UK. Heart failure, diabetes is in there, and that's because if you have diabetes, you're 2 to 3 times more likely to develop CVD. So we treat people with diabetes with secondary prevention. This is some data from the British Heart Foundation, and it just shows the impact of CVD on our hospital admissions, people having strokes, and the cost implications of these strokes because of not only to the patient but to carers who might have to leave work to care for their loved one who's had a stroke. It's also a cause of death. So what can go wrong and why? Well, here we have a picture of the vessels leaving the heart and going to the other major organs within the body. And on the right hand side we have a picture of the heart itself, and the heart needs its own blood supply, and it gets this via the coronary arteries. So on the right we've got the right coronary artery, and that it's a bit like tree roots around the heart feeding it. So we have the right coronary artery, then we have the left anterior descending artery and the circumflex artery, which goes around the back of the heart. CVD, it's a big problem, but as you can see from this graph, actually we have seen a lot of improvement over the years. So the total CVD mortality has declined by 68% between 1980 and 2013, and that's within the UK. However, the prevalence has remained the same, so we still have the same amount of people with CVD. So it accounts for 3% of people in England and 4% of those in Scotland, Ireland and Wales. So what's caused this decline in people dying from CVD? Well, lots of things have been happening over the years. In 2000 we had the NSF, which then set up the CVD registers and hypertension registers, etc., within surgery. We've had the 5-year forward long-term NHS long-term plan. We've had cardiovascular outcome strategies. There's been nice guidance. The 5 a day with the fruit, smoking cessations, services, and obviously the campaigns and regulations around smoking in the workplace and in pubs and clubs. We also now have limits on how much alcohol we should drink. There's also better treatment for people with CVD and interventions. So we have things like bypass surgery and angioplasties. Also medication, including statins, which have made a huge difference. More recently, we've had health checks and risk registers. So this study looked at healthy, asymptomatic, fit people, mainly men, 98.8% were male, soldiers who died in combat. And what they found was that 8.5% of them had some form of coronary atherosclerosis, and that actually increased with age, which we knew. But I think the thing that sort of shocked me most was that 6.6% prevalence in those under 25, which shows that this is a lifelong condition and something that doesn't just happen overnight. So what causes this atheroma? So we've got a picture here, and we've got a normal coronary artery, and you can see the endothelium within that artery is nice and smooth. But when the endothelium becomes damaged, it causes inflammation. And then cholesterol can accumulate within that artery wall, and it oxidizes, rusts, if you like. This then causes further inflammation, and white blood cells, which we know treat inflammation and infection. So the monocytes, which are white blood cells, enter the artery wall and transform into microphalanges, which attempt to digest the cholesterol. So it sort of encases the cholesterol, and this forms a foam cell. Within the arteries, these foam cells degenerate and they release their contents, which causes this atheroma. So it's a bit like a porridge. And then over the top, we get calcium salts and fibrous tissue that accumulate, and they cause this hard plaque over the porridge, over this softer atheroma. Here we have a picture of an angiogram, and if you look at the top of the picture, so we have, just try to get the cursor to work, so we have here, you can see we've got narrowing of this artery, and this means that the blood's taking longer to get down to these coronary arteries and feed the heart muscle. If there's a total occlusion of this vessel, then that's when we get death of heart muscle and a heart attack can happen. We're now going to have a look at what causes this furring up, this atheroma within these artery walls, and then talk about how we can manage some of those and how we can then support our patients into making these lifestyle changes. So the InterHeart study was a very large study that was done over 52 countries, and they looked at what risk factors attributed to causing patients to have heart attacks, myocardial infarctions. And what they found was that there were 9 potential modifiable risk factors that can cause or lead to MIs worldwide. And they found that it was the same in both sexes, at all ages, and all ethnic groups. So these were all things for whoever you were that could lead to you having a heart attack. As you see on the right hand side, some of the bigger causes are smoking, cholesterol, and blood pressure. And they form half of this diagram. Our modifiable risk factors are smoking. So smoking causes speeds up that atheroma within the artery wall due to the inflammation it can cause. The best results to stop smoking are using nicotine replacement therapy and behaviour counselling, or something like Champex, again with behaviour counselling. And most areas also recommend vapes, as long as they are obtained from the correct suppliers who can support with the amount of nicotine replacement that's added to the liquid that's put in the vape. 2 NRTs are better than 1. So something like a patch that gives that constant nicotine to help with the craving, and something that gives that hit. So if you remember, smoking can hit the brain barrier within 5 seconds. So you get that dopamine release, that's that pleasure hormone, very quickly. So something like an inhaler or nasal spray that gives you that quick hit is very good for some patients. Hypertension. So again, if you have hypertension, that causes turbulence within the blood supply that's going down our vessels, again causing damage to the endothelium and speeding up that inflammation and atheroma. So we like patients to keep their blood pressures controlled to below 140 over 90 clinic reading, and 135 over 85 for our ambulatory or home blood pressure monitoring levels. Obesity. So here we want to keep those waist ratios. So for a man, below 94. If they're South Asian, then it would be under 90 centimetres, and for women 80. And BMIs, we like to keep it below 25. Cholesterol, hyperlipidemia. Some people will have familial hyperlipidemia, and it will run in their families. So it's important, if you have somebody with a raised cholesterol, to actually look at their family history, as they may need to be referred to a specialist. So we know we have our good cholesterol and our bad cholesterol. So our HDL, which is, I always call it my happy lipoproteins, are the good cholesterol, and they take away the excess cholesterol from the blood back to the liver, where it's broken down and removed from the body. The LDL is the lethal, the bad cholesterol, and that carries it actually carries cholesterol to the cells to help with their function. So a little bit of cholesterol is actually good. It does help with cell function, but too much, that's when it starts, hanging around the artery walls and gets engulfed, making those foam cells, as discussed before. So that's the bad cholesterol. So we can treat this looking at the patient's risk. So if we do a risk assessment of the patient, then it may be that we need to give them atorvastatin to prevent further risk of CVD. And there's been lots of trials to show, even with 10 milligrams of atorvastatin, that it can reduce MI by 37% or stroke by 48%. Then salt intake. Advise patients to keep their salt intake down to below 6 grams a day. And there has been a lot of work with food companies to reduce the amount of salts in their products, especially cereals. And Then we have alcohol intake. So now the recommendations are 14 units a week, with 2 to 3 alcohol-free days. Diet. So diet recommendations are that we have whole grain varieties of starchy food, that we reduce our sugar intake, and also the refined sugars, such as fructose, that we encourage patients to have 5 portions of fruit and veg a day and 2 servings of oily fish. And then things like unsalted nuts and seeds, etc. Diabetes. Now, some people might think that diabetes should be in the non-modifiable, and of course type 1 is, but lifestyle usually leads to that metabolic syndrome, which then leads to diabetes. So we should treat our diabetic patients as if they already have CVD. So we treat them with secondary prevention. Physical activity. So we recommend that patients should exercise for 150 minutes of moderate intensity aerobic exercise per week, or 75 minutes of vigorous intensity aerobic activity. And along with that, they should do some muscle strengthening activities for 2 or more days a week that work all those major muscle groups. Now, as health professionals, you will know all of this. And hand on heart, how many of us actually practice what we preach? Or we might go through periods where we think, oh, I've put on a bit of weight, I'm going to go on a diet, and you start eating healthy. You know, I will reduce my alcohol intake after next week because I've got a wedding to go to, or, you know, I'm away with the girlfriends, or I'm on a stag night, or whatever. We make excuses, but we expect our patients to look at their risk factors, and we try to support them with making those changes to reduce their risk. But I think it's important to think, actually, you know, how easy is it to stick to these long term? And here are a few other risk factors. Erectile dysfunction, you know, this is a question that we don't ask routinely, but studies have shown that once a patient starts to get erectile dysfunction, that they have a high risk of CHD within 4 years. Now, why is that? Well, because it's an artery that feeds the penis, and it's about 1 to 2 millimeters wide. So if you start to get erectile dysfunction, that's usually due to atheroma within the artery within the penis. Now, a coronary artery is between 3 to 4 millimeters. So penile artery, 1 to 2 millimeters, coronary artery, 3 to 4 millimeters. So it's only slightly bigger. Our carotid artery is 5 to 7 millimeters, and our femoral artery is 6 to 8 millimeters, to put it into perspective. So it is an important question that we ask patients, do they suffer with erectile dysfunction? And I know that some systems that any of you that do health checks have that built into, but I also know that some people that I've done teaching with have said that actually it's no longer there. So an important question that should be asked. Here we have a study that was done looking at the effects on modifying our risk factors to reduce blood pressure, and even I think it's important to remember that even a small drop in your systolic blood pressure can reduce MI and stroke quite dramatically. So obviously, if you add all these, if you reduce your weight, adapt your diet, reduce your salt, take more exercise and have less alcohol, you can't add up these totals, but you will have a good reduction of blood pressure. When doing my consultations, I use the Carl Rogers 5-step stages of counselling, because I feel that it fits in really well with consultation skills. So stage 1 would be to identify the need and create the climate. So firstly, ensuring that you have an area that is conducive to having these conversations. Now, I know most of us, we have to put up with whatever we get, be that a cupboard or whatever, but the location is important. It needs to be quiet and you need to be free from interruptions so that you can concentrate and listen to the patient and listen to what they're saying. Temperature should be right, not too hot, not too cold. Lighting as well should be good. Should be tidy and free from clutter, and also be mindful of the posters that might be on the wall. I did a clinic that I happened to share with the midwife and the health visitor, and one of the patients did say he was rather put off by the breastfeeding poster. So, maybe just take it down or put another poster up if you're doing a different clinic. And also getting that seating arrangement. But part of this identifying the need is actually setting the agenda. So this needs to be the patient's agenda, not your agenda. So asking questions like, what would you like to get from the session today? Or tell me what's happened so far. So when I did heart failure, I would say to the patient, tell me what you know about heart failure. What have you been told about your heart condition? Or, when did you first realise that there was a problem? What was it that that happened? So from that, you can also find out patients' health beliefs. Often they have incorrect health beliefs or have poor knowledge about why they're there and what's going on. So it just forms the agenda, what you're going to get from that time. And also it's a good time to actually put a time limit on things so that they know how long they've got with you. Sometimes when you ask a patient for an agenda, they might come up with a huge list. So what I do is I then ask them what are the most important things they want to discuss, because obviously you can't do a huge list, and you can then find out what's most important and then say to them, if we have time, we'll look at some of the others, or we will do that when I see you next. Stage 2, to explore the needs and concerns. And I've got here about using open discovery questions and open listening. So it is a skill to actively listen, because quite often when we're listening to a patient, we're also formulating what our next question is. But you need to try and just concentrate on what's being said. Listen for those keywords. And quite often we ignore keywords because of time restraints. But by doing so, actually, if it's the most important thing for that patient, then they may not listen to anything else that we need to tell them that day. Avoid giving advice. Advice giving should be when a patient asks for it, or to confirm or support the conversation that you've had. So it might be, during this consultation that you talk about, patient might say that they're not sure what's out there, might want to join a walking club, or where Slimming World classes are and you can give them that information then, but avoid trying to give an advice, because actually trying to get patients to, or supporting patients to build their own action plan and identify what they feel that they can tackle first is more likely to happen. Who likes to be told what to do? None of us do. So helping patients set their own goal, which is stage 3, is actually a really good way. So going back to stage 2, in that active listening, we want to clarify the patient's understanding and also our understanding of what the patient's saying. We need to reflect back, so on asking questions to show we're listening, and to ensure that you've actually heard right. Reflect back. As I said, be attentive and focused, and also encouraging. And then summarise what the patient said to you. So one of the skills that I use to help with goal setting is, first of all, trying to find out how important making those changes are for patients. So I use the questions, how important is it on a scale of 0 to 10 for you to make these changes? So for instance, if it was me and you asked me, how important is it for you to lose weight, Trish, on a scale of 0 to 10, I'd probably say it's about an 8. And then you would ask the question, so that's really important. So what makes it an 8? Why isn't it a 2 or a 3 or a 4? What makes it that important? And that's reaffirming to me that it is important and that you realise it's important. So then I'd answer, well, actually, I've got my daughter's hen do and wedding coming up, and I don't want to look like a beach whale on around the pool in Ibiza with all these youngsters that we are going, and I want to feel comfortable in my outfit that I've bought for the wedding. Then I wouldn't leave it there as the health professional. I'd say I'd reflect on what was said. So you're saying that you have a wedding coming up and you want to look good in your clothes and look good on the beach. So, but what else makes it important? And then I'd say, because I'm not getting any younger, I suffer with arthritis in my knees, and I know when I'm overweight that causes more pressure on my knees and gives me more pain. Then you go, reflect back what I've just said, and then say, what else makes it that important? And I'd say, because I have a lot of clothes in my wardrobe that I struggle to get into. And reflect back, ask again, what else makes it important? Until the person says, no, that's it. And then reflect back all those things. So you want to look good at your daughter's wedding and at the hen do. You want to, for your health reasons, to help with your knees, and because you have lots of clothes in your wardrobe that you can't fit into. So I've already made a list of how important it is. And by asking if there's any more, actually some patients increase on their importance, because they then go, actually, it's more important to me than I've realised. I would then, as the health professional, ask me, how confident are you that you can lose this weight? And you can get back into that wardrobe and feel good at the wedding. How confident are you? And I'd probably come back with saying I'm about a 5 to 6. So then you would ask, what would make you a 6 or a 7 or an 8? What can you do to make yourself more confident? then I'd probably come up with things like, well, my daughter and I were going to the gym, but 3 weeks ago I had COVID and I haven't gone since, so I need to pick that up again. Need to start going to the gym because we support each other. So she hasn't been going because I haven't been going, so we need to do that. I need to ensure that if I'm working from home that I eat a healthy lunch and I don't just go down and snack out of the fridge, but actually have lunch ready so that I eat a healthy lunch. I need to ensure that my work colleagues don't shove cake under onto my desk and encourage me to eat unhealthy things. And then I'd come up with things that I could do. So I'm already forming that action plan. I'm already, from those 2 questions, how important is it? How confident am I? We've already gone through some of those stages. And, I've already started to formulate that action plan. But you can then, to help take that further, you can then ask, so what are your next steps? What are you going to do next? What are you going to do when you leave here? And I can, I'd say, well, I'll get in contact with my daughter, see if she's free tonight so that we can go to the gym. And then I'll, which I will do, by the way. It's about taking that a step further. Now, I might say, actually, I've tried different diets and they really haven't worked. Can you recommend, can you give me any information on healthy eating? And then, as a health professional, that's when I give the leaflet. Now, quite often we pat ourselves on the back when our patient leaves and we've given them this information and they go on their merry way. Now, I've already said how a lot of us fall off from doing these great things. So I was, doing these great things. I did my action plan. As I said, I had COVID. It's all gone a bit tits up. So what I then need to do is call that person back. So call the patient back, have a review date, see how they're going, see if they need more support. You may have seen this many times before, and we do have to remember that patients are not always ready for that change. So when we did the how important is it to you, they might only come out with a 4 or 5. I enjoy my cigarettes, I don't want to give it up, but still having that conversation, listening to what their health beliefs are, then sometimes we can trigger in that patient that actually maybe, speaking to the nurse, perhaps I do need to do something about my smoking. So you might not have a win on that day, but you might get the patient to that pre-contemplation stage. Then, another reason to get them back is you can help them further onto their journey to that contemplation. Then you get people who then start to make those changes, they have the actions, and they have a maintenance period. But we all know that it's very, very hard to keep that maintenance, and we all have relapses. So that's why it's important to do these annual reviews on patients so that we can reinforce and support them. So see what the patient's health beliefs are and use open discovery questions. Reinforce positive ideas and feeling of control. So by using this technique, the patient is in control. They are deciding what they're going to do. Patient might ask for information, and that's absolutely fine. We can then give information. They might say, I've tried everything. I don't know where to go next. And if a person is over, in obese with their BMI, in many areas we can offer them weight loss sessions. So, that's when we give the advice. That's when we give the information. If they come up with negative ideas or misconceptions, firstly, don't encourage those. So I was doing some smoking cessation with a patient, and I had a student nurse in with me, and in one of my pauses she said, "Oh, but it is hard, isn't it?" And I'd lost the patient. He was then, yeah, it's hard. It was almost confirming his negative ideas and his health beliefs, and reinforcing him in not wanting to not wanting to take that forward. Eventually we did get him to stop smoking, but it was a bit of a hiccup. Inform the patients. So as I said, give them the information if they ask for it, or you feel that you can help them further. So if they're, in their plan, they say, "Oh, I want to do some more exercises, I need to know about some walking classes," and you've got that information, then give it to them. And as I said, plan and agree with the client a suitable course of action and get them back. So if you want to know a little bit more about CVD, we do run some workshops, and it'd be lovely to see some of you come along and join those. This slide shows the email address, so just pop an email and we can give you more information on CVD courses, heart failure courses, diabetic courses, etc. Thank you for listening.